Quin Liu, who's an assistant professor of pediatrics in Cedars-Sinai, and he'll talk about endotherapy applications in pediatric disease.
Thank you so much again for the invitation and the opportunity to present to you all. So I'm a pediatric gastroenterologist by training, and somehow right now at Cedars-Sinai I'm doing both adults and children, so I have my feet in both worlds right now. And I was preparing this talk kind of in preparation, thinking that Dr. Papacristo would be have already done his talk on endotherapy on chronic pancreatitis and acute pancreatitis. So my focus was really just to see if I could show you and discuss the differences in peds endotherapy compared to just endotherapy in general, adult endotherapy. Just want to start off in terms of, why we want to do this. So sometimes at the beginning when we talk about medicine in general, some people refer to kids, our children are small adults, things like all endoscopes and endoscopic accessories can be utilized for pediatric endoscopic cases, and adult data can be extrapolated for pediatric management, right? So we know that's not true. We know from Dr. Abu El-Hajjaz's talk that even the etiologies, of course, are different, and therefore we have to think our treatment modalities can have to be different too. And from endotherapy standpoint, there's kind of two things we have to kind of look at. Both is the technical aspects of everything and the medical aspects in terms of whether it's going to work and whether it's going to be helpful or not. So in terms of just breaking it up, I'll talk first about like ERCP and then EOS and the differences in endotherapy from an adult standpoint, and mainly in terms of what are the special considerations for pediatrics. And when it comes to ERCP, when we think about ERCP, usually we talk about using a quote unquote therapeutic duodenoscope, the therapeutic ERCP side viewing scope. And that's the one here on the far left, which is the one that we are normally able to use and get down and do our work and do our therapy, because it gives us the most options in terms of accessories and what we can use to treat patients. Now, there is this non-therapeutic side viewing scope, which doesn't seem like it's really manufactured anymore. So if you do have one of those, please hold on to it. And then I'll refer to this as a non-therapeutic one. And then there's this infant one, which is not manufactured anymore, and sometimes is even hard to repair if it's broken. And you could tell there's some differences that it has a metal tip to it. So what we have to know about these is that when you do work, because this could be just a pediatric gastroenterologist doing this, or many times the adult gastroenterologist doing these procedures on children, is that to know exactly the sizes of these so you can understand what may be utilized for what children. And like I said, the therapeutic one is the one that has the largest working diameter that allows us to use a lot of our accessories and tools. Whereas the non-therapeutic one, you're able to do many things, but not everything due to the smaller working channel. And the infant one is very limited due to the very tiny working channel, which is the same thing as an infant gastroscope. So when can we use this therapeutic one, the quote unquote standard therapeutic duodenoscope? And usually that's in children that are 10 kilograms or greater, so about a 1-year-old. And at least that's when we can at least try to see if this normal side viewing ERCP scope will be able to be passed down the infant or very small toddler. Now, let's say you can even pass it down, then there's still some issues in terms of what you can do once you're down there. So of course, the biggest thing is getting it down and intubating the esophagus with it. And then the second issues are sometimes, once you're able to get it down, make sure you can get it past the pylorus. I've had a few instances where I could get it down a toddler, but can't get it past the pylorus, so I have to downsize the scope. But other things we have to consider is that when you're in the duodenum and you have to put your side viewing scope in the normal short position, we have to reduce the scope. You have to make sure that you don't reduce it too quickly or in the right position, because there's always a chance of reducing that larger scope in the smaller lumen of duodenum, and you have a risk of causing a duodenoscope perforation. And the videos on the bottom, the one on the left is a 3-year-old ERCP. The one on the right is one in an older teenager. And I was just showing them just so you can see the amount of maneuverability you have in the duodenum between the two. While the one in the 3-year-old, you can see the scope is basically straight. You have a poor angle to access your pancreas or bile duct compared to the 14-year-old, where you have a better kind of that hockey stick look to your duodenoscope to get in a better position underneath the papilla. But let's say you can't get the larger or standard duodenoscope down. When you have to use the infant duodenoscope, you have to understand what your limitations are. You just can't use everything you have in your ERCP arsenal in terms of treatment, whether it's pancreatic disease or biliary disease. So like I said, it's a 2-millimeter working channel, so you have to understand that's only a 5 French accessories can go in. So there's no biliary stents that will pass through this. There are pancreatic stents that can, but sometimes they're even hard to get through. There's one sphincter tome on the market that can get down. There's one cannula that can get down. There's one stone extraction balloon and one basket you could use. And there's a dilated balloon that if you really lubricate it, you can shove it down there and get it through. You might have a hard time getting it back out. And you might even risk breaking your scope trying to do that. And like I mentioned earlier, there's a metal tip. So if you're trying to do a sphincterotomy, you have to be very cognitive that it can conduct heat. Like the cutting wire can conduct heat to the metal tip. You can cause a duodenal mucosal burn and thermal injury on the contralateral side of the duodenal wall compared to the papilla. And also the elevator itself is not very good. The elevator, this is an image of a 3 or 4 month old ERCP, and this is the highest I could get the sphincter tome to go up, while normally it goes up to that direction. So your angle of cannulation is a little bit more challenging too. So usually we try to get basically the largest duodenoscope that you can down, but in times that you have to use the infant one, you just have to understand what your limitations are prior to doing any biliary or pancreatic work. Thankfully, usually it's less likely we have to do pancreatic work for infants, but it's not, but it does occur, of course. Of course, the second question is how helpful is ERCP in the pediatric population then? In the INSPIRE cohort that my son had alluded to earlier, Dr. David Trendle, who's here at Pancreas Fest, published a paper on the cohort of patients with acute recurrent pancreatitis and chronic pancreatitis and ERCP in those children. And not surprisingly, those patients who had chronic pancreatitis had more likelihood as having ERCPs done. But the question is how helpful it is. And you can see in red, overall, the percentages weren't that great, anywhere from 40 to 60%, other than when they're treating pancreatic duct stones, which seems to be more likely in terms of being helpful. But the limitations of these was that overall, the endpoints were not really objective. It was based on physician questionnaire. It wasn't whether they had another episode of pancreatitis or not. It wasn't randomized. It was really looking back retrospectively on, although prospectively gathered data. So overall, I think the jury is still out in terms of the helpfulness of ERCP in recurrent acute pancreatitis and chronic pancreatitis. In terms of pancreas divisum, Dr. Tomlin from Cincinnati has looked at this in several papers. And overall, ERCP in his findings seems to be very helpful. Again, in basically pancreas divisum and chronic pancreatitis stemming in pancreatic duct stones. In terms of recurrent acute pancreatitis and pain, it's not as clear. Dr. Reddy in the Asian Institute of Gastroenterology in India, who does a lot of this, talks about pancreas divisum in the setting of also having a CFTR mutation as maybe having a higher chance of being more therapeutically successful, thinking that maybe it's more of the pancreatic fluid secretions being thicker and the papillotomy being more helpful in terms of drainage. Now, just a couple other papers on ERCP for pancreatitis in children that are relatively more recent, or at least with longer follow-up. In this group of 200 ERCPs in pediatrics, they looked at 5 subsets of patients with chronic pancreatitis and pancreatic stenting, and to see how helpful that was. And what they found was that the median episodes of ERCP procedures was about 3. And the interval between the procedures was about 4.5. But what I wanted to show is also that before ERCP, they seem to have about 1 3/4 episodes of pancreatitis per year, and seem to significantly decrease after pancreatic duct stenting and ERCP with a decent follow-up time. Same with this paper from China, where on the left on this graph, you can see these are episodes of pancreatitis and abdominal pain, and on the right, after ERCP, seems to go down much less. Now, the thing with these studies is that they're a very heterogeneous group, and the treatments that they did endotherapy-wise was also very heterogeneous. Some had just stenting, some had stone removal, some had dilation. So they're not very well controlled. All these studies are not very well controlled, and that just brings up to the issue in terms of, I think the jury's still out there in terms of how helpful, at least long-term, in terms of endotherapy and the overall outcome in children with acute pancreatitis and pancreatitis too. Now, the other thing we have to keep in mind is radiation exposure in children. We're using real-time fluoroscopy, and in this data that was presented at DDW, we looked at a ERCP database in children and found that those patients who were getting their ERCPs done for pancreatic diseases and chronic pancreatitis had a significantly higher radiation exposure time compared to other children, increasing their time to fluoroscopy. But not only that, those patients who are having ERCPs for recurrent acute pancreatitis and chronic pancreatitis, whereas all comers who were having ERCPs, there was about a 36% of those children were having repeat ERCPs, and those with recurrent acute pancreatitis and or chronic pancreatitis was reaching anywhere from 57% to 60%. So not only are they having longer times on each procedure in terms of fluoro exposure, they are having repeat ERCPs too. So there are things to keep in mind when we're offering this to children in terms of future outcomes and radiation exposure too. And then also in terms of post-ERCP pancreatitis, adult data has shown that this seems to be mitigated in terms of decreasing risk of post-ERCP pancreatitis with pancreatic duct stenting and rectal endomethacin. The thing is that the pediatric data is not very clear at all. If anything, there is data that suggests that even things like pancreatic duct stenting may trend more towards increasing risk for pancreatic post-ERCP pancreatitis, and this has been reproducible in studies such as the one done by Dr. Matt Geifer at Seattle Children's, again, Dr. Trendle, and in this ERCP cohort here too. So it's things to keep in mind that not everything that shows to be helpful in adults may be translatable to pediatrics. And then also endoscopic ultrasound, which unfortunately has even less data. These are just images of the linear echoendoscope. And this is the ones that we use for more therapeutic endoscopic ultrasound, things like fluid drainage, aspiration, cysgastrostomies. Now, same thing that on these echoendoscopes, the therapeutic ones and the linear ones are actually sometimes larger than the ERCP scopes. So in terms of getting these echoendoscopes down children, sometimes you have to be even more cautious because the bend here is actually longer because you have the ultrasound tip extending that length. So sometimes when we have to get this therapeutic linear echoendoscope, which is the ones we have to use sometimes for cysgastrostomy and drainage, it might be even more difficult. And usually we're able to get these scopes down when a child is 15 kilograms or greater, so about 3 years old or so. Otherwise, EUS has been shown to be, at least from a technical standpoint and safety standpoint, same outcomes and same safety as in adult data. And when you look at all the studies that look retrospectively on centers and their experience with pediatrics and endoscopic ultrasound. But the issue is, how do we use it? Right now, although there's Rosemont criteria and conventional criteria for sonographic changes for pancreas parenchymal changes, there's really no standard for pediatrics, and we don't really know how well these things translate in the pediatric world. Like, we will see things like hyperechoic straining and lobularity. But if we see a 1 or 2, does that mean that they're at more risk of having pancreas issues, less risk? Those are things that are still out there that we're not sure how to really interpret long term. And in terms of its use for idiopathic pancreatitis, there's adult data that shows that it might be helpful in identifying biliary etiologies, or in pediatrics, again, that still needs to be borne out, and we're still something that we had to further study. Because right now it's not standard to really do endoscopic ultrasound on patients with their first acute attack of pancreatitis and recurrent acute pancreatitis. There's no really established guidelines yet right now. Now, in terms of therapeutic EUS, studies have shown it can be done, and what I mean by that is mostly the cisgastrostomies. Studies have shown pigtail stents being technically feasible, technically safe and effective, and also same with the lumen-opposing metal stent, again, with paper by Dr. Kiefer and others. And there's actually a presentation at DTW a couple of years ago comparing the lumen-opposing metal stents, which are these metal stents that are designed for drainage of the pancreatic fluid collections, compared to double pigtail stents, and they found it to be superior. Even though I couldn't find the reference, it was presented at DTW a couple of years ago from headed by the group in Jefferson. But just a note of caution is that anecdotal evidence when discussing the placement of these lumen-opposing metal stents in smaller children, like 3-4-year-olds, we've seen a lot of children not tolerate them very well from the standpoint of a lot of vomiting, pain afterwards, and they seem to be needing to be removed much more earlier than anticipated also. So just a little word of caution there. So in summary, I think in terms of endoscopic therapy for kids, just really keep in mind the differences in terms of what is available, especially in smaller kids. Again, the data is still out, still needs to be hashed out, I think, in terms of how effective it is in children for pancreatic diseases. Data seems like it shows that it helps, but some, follow-up in children is really a long-term thing in terms of as they head to adulthood. Otherwise, I think EUS still needs to be looked at in terms of its future role in the management and diagnosis in children with pancreatic diseases. Thanks.